let's do that. We got our questions. All right, Josh. So we're back again. And this week, we're going to do something a little different. Something I have never really talked about, or you and I have never talked about. And not too many guys ask questions about this, but there are some. We're going to tackle TRT and urinary health.
Yes,
Yeah,
right up my wheelhouse.
I figured this would
So
be this. If there was someone that I could think of to talk to, you would be the top two.
great.
And Jesus would be the other one. So it's
Yes,
like,
happy to assist increasing stream strength.
that's it. Stream strength.
Yeah, don't
Sounds
want
like
a
a
weak
t-shirt.
stream.
No, you want a TRT stream.
Yeah.
Good, strong stream.
What was that movie? I think it had Shia LaBeouf in it, and like the kid's peeing in the toilet, and he's like, "Look at that stream. That's like a pussy stream right there." He's like, "You need to have like this man stream right here." And
What? Really?
he's
Oh,
into the
dude, I
toilet.
gotta fucking look that up.
I think it's Honey Boy. I think that's what it is.
That's fantastic.
He's like
That's a
peeing in the
pussy
toilet.
stream.
Like, he's basically saying it like it's like this little wimpy stream. He's like, you need to make it sound deep, when
Dude,
you're
hold
peeing
on.
in there.
I gotta say something real quick. I don't know if anyone like when my wife pees at night, there are times that I have woken up while she's peeing thinking that a pipe broke. Because it sounds like if you've ever worked and a pipe breaks, that's what it sounds like. Like the water, it just doesn't sound like I'm used to when I pee. It sounds it's like that, like it's thunderous.
Like
But
Austin Powers when he's standing against the he's
yeah,
like
right. It just keeps going. Yeah, it's happened like probably 5 times in my marriage over
it's
what is it,
funny.
17, 16 years or whatever, where I hear a pee and I wake up like fuck, like it's a fucking pipe break or something. Those fucking girls. All right, so Josh, I have a few questions. I think it's like 6 questions
Cool.
about TRT and urinary health. So let's just jump right into it. Does TRT make you pee more often or especially at night?
Okay. So I think the first thing we're gonna just throw out here at blanket. Okay. So I know there's probably gonna be a lot of questions is does TRT cause X? Does
Yeah.
TRT cause Y express urinary symptoms? And we can continue to ask those questions, but I want to start out by saying TRT does not directly increase your risk of urinary symptoms. Okay. And when we're going to talk about urinary symptoms, I will break them down here. We'll talk about BPH. We'll talk about some bladder health issues because they are separate than what you think they are. Oftentimes we think, well, if I'm peeing, oh, it's probably my prostate. No, it's a prostate, not a prostrate. There is no R. What the fuck are you talking about? you know?
Walk right
So,
into that one.
yeah, definitely. So just remember it is a prostate, okay? And oftentimes it gets attributed as being like the culprit for everything, but often it isn't the culprit. Sometimes it's your bladder that's the issue. So kind of teasing out what type of symptom you have can really, make it, is it a bladder issue? Is it a prostate issue?
Mm.
Okay. And a lot of times it could be a bladder issue. It could be a pelvic muscle floor
So wait, is that
issue.
what so a lot of people, that's what they like assume right off the bat that it's a prostate issue, but
Everybody, I think, automatically just
it's
assumes, hey, it's a
prostate.
prostate issue. Hey, it's a prostate issue, right? Like, so urinary frequency, okay? This is a um, common symptom. Urinary frequency is very seldom related to your prostate, but it's almost always related to your bladder.
Mm.
Okay. So urinary frequency is what we call an irritative symptom. So I'll talk about those here in a minute. But
Okay.
back to the question, does TRT increase? What's the rest of the question? TRT
It says, does TRT make you pee more often, especially at night?
Okay. And we'll talk about nocturia, which is urinating at night. We'll get into that too. So TRT does not directly increase your rate of urination, nor is there any definite data to show that it causes BPH or growth of the prostate, or benign prostatic hyperplasia, okay, non-cancerous growth of the prostate. We don't 100% know, like 100% what causes BPH, okay? There's not a single cause, but there's some that are kind of known and there's some that are kind of like thought of, but there's no like definite, like this is 100% the reason why it does it for all the time. Obviously we know DHT has a factor. of making the prostate grow. But just because you go on testosterone and theoretically you'll make more DHT, it doesn't necessarily mean that that's necessarily going to make your prostate get larger. Okay.
Right.
So, and here's the other thing. I've had some guys with some really large prostates pee perfectly fine. And I've had guys with some really small prostates have terrible urinary symptoms. So it's kind of a mixed board here. I mean, in general, yes, typically as the prostate gets larger, the percentage of urinary symptoms that men have symptoms increases. But it's not like that for everybody, so to speak.
What are the urinary symptoms that you're talking about?
We're going to break those down into two categories. We're going to break them down into irritative symptoms, and we're going to break them down into obstructive symptoms. Okay.
Mhm.
Irritative symptoms are typically bladder related symptoms. Obstructive symptoms are prostate related symptoms. Okay.
Mm.
And they are treated two very separate ways. Okay. So if we're talking about irritative symptoms, we're going to be things that are like frequency, urgency, like the sense that you kind of have to pee all the time, right?
That's gotta suck.
And to a lesser extent, getting up at night to urinate, nocturia. Nocturia is like a multifocal thing, and we'll talk about that last. Obstructive symptoms are going to be like weak stream, okay, dribbling, double voiding. Like double voiding is like when you pee, you stop, you pee again, right? A sense of incomplete bladder emptying, right? You're like, I just feel like I can't get all this out of there.
Mm.
Okay. And maybe you aren't emptying your bladder. Maybe you have to have what's called a post-void residual. You go to the office, you pee, and they measure how much is still in your bladder with a little ultrasound scanner over your bladder to see what's left.
Oh, really?
Okay. Oh, yeah. Oh, yeah. We used to do that on a lot of people with if you were a new patient and you were seeing me in neurology, I'd get a PVR on every new patient.
No shit.
Just so I knew you were emptying your bladder. And
So
here's the thing.
rule that out just from the beginning.
Boom, done. Simple. Okay, you've got 50 cc's left in your bladder after you urinate. Like very few people empty like completely. They're usually empty to like 50, 60, 70 cc's in your bladder. That's pretty typical. Okay. I wouldn't really get worked up unless somebody was like 200 plus, essentially. And even then it's like, okay, we're going to try to get you emptied out better. Try some medications, this, that, and the other. So those are the two differences in symptoms, and treatment of the symptoms is also different, right? If I'm going to treat an obstructive symptom, I'm not going to treat it like an irritative symptom. So obstructive symptom treatments are going to be for the prostate, and these are going to be things like alpha blockers, which is like Flomax or tamsulosin, alfuzosin, silodosin, and then you've got the real old dogs. Like I always tell like how old somebody's PCP is, and they come in and they're on like doxazosin. That drug's been around for like years,
right?
And I can always tell like they probably have like a really old family doctor or whatever come in on doxazosin, and I'm like, how long have you not been on that? For 30 years. And I'm like, I bet you have. Like,
doctor's 87 years old.
Right. I'm like, because like nobody prescribes that anymore,
right?
Because the newer alpha blockers are just better. Flomax is easily the most common one. Tamsulosin is like gold standard. There's obviously some issues with alpha blockers in general. They can cause some hypotension. They can make you feel lightheaded. So sometimes you have to get up slowly, especially if you take it in the morning. So we would always tell patients take it at night. So if you're a guy listening and you're on Flomax, and you're taking it during the day and you wonder why I feel kind of crummy, take it at bedtime. You won't feel crummy during the day. So
will that last all day? If you take that, you just take it once a day? If you take it
during the day, it can last a couple hours where you feel like just you can't get your feet underneath you. Some guys feel that way and they feel kind of crummy. So it's because your blood pressure is too low.
No shit.
We have guys take it at night and then they're just going to go to sleep, and then it's not a big deal. So
damn.
Yep. So if that was the case, I'd switch them onto like a not as strong alpha blocker, maybe like alfuzosin or silodosin.
Is it recommended to take it at night? Is like on the float? Oh, so
I mean, it's not recommended. That's more of like a caveat thing.
Okay.
Like
so it's just if you
thing.
have that issue, then you should.
And you can theoretically take up to 2 tablets. So the Flomax only comes in one strength, it's just 0.4 milligrams, and you can it's approved up to 0.8 milligrams per day. Okay, or 800 micrograms essentially. In Europe, it's actually approved up to 1.6 milligrams a day, which would be 4 tablets. But like, there's no reason, because if you're taking 2, taking 4, sure shit is going to make it any better. So,
right.
But yeah, so it generally works pretty well. And that medication works by helping relax your prostate. So if you're having a hard time getting the urine out of your bladder through the prostate because it's so swollen, I shouldn't say swollen, it's just so large that um, I guess I should back up here and kind of just give some brief anatomy of the prostate. So your prostate's about the size of a walnut, okay? And it's right up underneath where your bladder is. Um, and it makes up the portion of your urethra called the prostatic urethra. So it actually, oftentimes I think when we look at like anatomy, we think like the urethra is like a tube that goes through everything.
Right.
It's not. It is a channel, but the channel is not like a separate piece of tissue. The channel is made up of the tissues at the spot that it's at on the way out. So like you have your bladder neck that feeds down in, and then you have the prostatic urethra, and then you kind of have the bulbous urethra, and then you have like the pendulous urethra, which is kind of on the way out all the way towards the end. Okay. And you kind of have, it's, a straight shot, but you can kind of tell where you're at by just going, like, if I was looking through a cystoscope, I could tell like, okay, I'm here. You just know just because of the anatomy, and you can kind of feel like where the scope's at in there and everything too. So, all right. So the prostate has 3 lobes.
Oh, hold on. I got a question real quick. How do you go in? How do you use that?
How to use what?
That tool, what you were just saying, you go in there.
The cystoscope? Right through the front door, buddy.
God, I fucking knew it. My
Goes
stomach
all
turned
the
as
way
soon
up
as
there.
you said that. I was like, oh,
it's a catheter with a camera on the end.
Yeah.
That's essentially what it is. So, I mean, it's nicer to have one of those put in than a catheter, because at least that I can see where I'm going, and I can also control the head. So it's like, like the Navy SEALs, they put like the little fiber optic thing down, they can like move it around. That's exactly what that does. So the reason that's nice is because if I have somebody that has, let's say, a really large prostate, or they have a really big hook at like the bulbous urethra, and I can't get it around the curve, I can angle it up and then go whoop, and then right up and through.
Oh, no
and
shit.
The urinary sphincter's right there too. So you have to go through that, and then up, you see the verumontanum, and then you see the lobes of the prostate, and then up into the bladder.
No shit.
It's pretty cool. I did a lot of cystoscopies. I really enjoyed it. I say I enjoyed it. I enjoyed it because it was a great tool to be able to to actually be like, oh, okay, like I'm going to be able to tell you either it's something or it's nothing. You know what I mean? So it was a really good diagnostic tool. And it took a certain amount of skill to be able to manipulate it. And I was lucky enough to have some really good docs to work with that, helped train me and allowed me to do that. And, it was a great skill to develop and continue to use. So, at any rate, once you get to the prostate, you have 3 lobes. You have 2 lateral lobes and a median lobe. Okay. So think of your prostate like a triangle. Okay. And if we're going up through it, the median lobe's kind of on the back, like right at the base. And then the lateral lobes are like the sides. Okay. And what happens is you can have, as your prostate gets bigger, if this is the hole, I know this is audio, but like if you're making a triangle with like both of your hands, okay, and like let's say that's the hole. When you get BPH, just slide your hand over the other, and now the hole is like that. Right, exactly, because the prostate's growing into that channel, and that's what makes it so hard to be able to urinate. Okay, so now exactly. So instead of having a channel that's like this, I now have a channel that's narrower because the tissue's grown into itself. Okay, so that's what makes it so hard to urinate when you get BPH. And then the median lobe, the back lobe actually can go up and indent the bladder neck. And it sort of, when you get through there, it looks almost like a little volcano. Okay.
No shit.
And depending on where the entry at the neck is, sometimes people's bladders would go down and then dip up and then have to come back out again. So those people you had to be careful with, because they were prone to like, their bladders wouldn't empty because there's always like this little
it's a fucking trap
on exactly. So stuff can kind of like hang out in there, and then you have to let it build up enough to where it can actually like go down in.
Okay? It's like the trap underneath your sink,
basically. Yeah. So and as that gets bigger, and then on top of that, you're peeing through a much smaller hole too, and that also creates back pressure to the bladder. And then if you're not emptying very well, you can get you could basically get what we call striations in your bladder, or trabeculation. And when you go in and you look, the bladder, if it's had to work so hard, the bladder's muscle is called the detrusor muscle. And what happens is when you go to urinate, your brain tells your bladder, it tells your detrusor muscle to squeeze and to relax your urinary sphincter, and that's what allows you to urinate. Okay,
Hmm.
it's an involuntary process. Obviously, like we can't just sit there and push and like make ourselves pee. Like we have to kind of get that process to get started,
Right.
right? And then it sort of has to happen, and then we can go. Okay. Um, but in somebody that has like a lot of pressure to do that, like that's what's going to cause like their weak stream. That's what's going to cause their double voiding. And so
Mm,
now we know like, hey, it's a prostate problem. And if
right.
that prostate problem is not mitigated for those obstructive symptoms, we could deteriorate the function of our bladder and then develop bladder problems down the road.
Jesus.
Yep.
Man.
And if left untreated and you get like let's say urinary retention, like where you're not emptying, and that urinary retention is severe. I mean, I've had people in multi-liter urinary retention where
What?
their bladders full. They look like if you do, it's hilarious. I should show you some of these CT scans. They look like they have a baby inside of them, and it's just their bladder full of urine.
I mean, can they feel that, or like, or you don't?
So here's the thing: if it happens chronically, if it happens over many, many years slowly, they don't really know.
Oh, yeah. I guess you
Like
just
because it
think
happens
it's
so slow.
normal.
But the people that have acute retention, oh yeah, it's very painful, very
I
painful.
can
But
imagine.
but you wouldn't have somebody in like 1.4 liter retention, right? That it happened overnight. There's no way. Like you don't
Right.
develop that level of retention.
Just, yeah. Right.
Just
That's over
like
time.
that's to get that bladder to stretch that far and to get that capacity that has
Jeez.
taken years. Okay. And what happens is when it stretches that big, their bladder essentially has no detrusor muscle to squeeze. So like they don't really gain function of their
So,
bladder very well.
so if you fix that, does their bladder go back? Like,
It
does it
it'll
shrink?
it'll it doesn't get as big because it's not as full as often, but you have to understand that detrusor muscle has now been like
That's what I'm
stretched.
saying. Like, it's stretched
Yeah.
out. Does it ever go like, will it work itself
Mm-mm.
back? No. So it stays like
No.
that.
It doesn't stay big. It does go back, but like you have to understand now the muscle because
It's
it's been
stretched.
stretched, its fibers instead of being like interlocked are kind of like this. And like its
Mm,
ability to squeeze effectively is really, really, really diminished. Okay.
no shit.
Yeah, we call that a neurogenic bladder. And that can happen from a couple things. It can happen from just being overinflated. It can happen from really bad diabetes where you lose the sense or the sensory mechanism in your bladder is gone and now you just can't sense and the bladder just doesn't squeeze
You can
because
get that from diabetes?
oh my god, yeah. 100%. That was my number one cause of neurogenic bladder. Diabetes wrecks everything, dude.
Yeah, no, I know.
It'll make you get your feet chopped off,
Yeah.
make you get your fingers chopped off. Your wounds don't heal really good, and yeah, it also causes gastroparesis, so it can happen to your bowel, and it can also happen to your bladder, and you can get a neurogenic bladder. And then it's one of two ways: you either obstruct or you're chronically incontinent.
Fuck.
Yep,
Jesus Christ, man. Don't get diabetes.
it's bad.
Yeah.
Well, I mean, if you do get diabetes, get it controlled, right?
Yeah.
Or if you have type 1, like really
Yeah. That's,
keep an eye on it, right? Keep control of your sugars, keep them under tight control, right? Um, don't let things get away from you. So do the best you can. And if you're
yeah.
type 2, then, work on getting in better shape and
That's it.
working on that. I mean, it's a process. I'm not here to shame anybody if they do
Yeah.
have type 2 diabetes or anything. It's a thing, but you know, recognize that with yourself and then go out
Yep.
and try to make some impactful improvements, right?
Yeah.
So, because I've seen some really nasty cases of complications from diabetes.
Yeah. I can
Yeah.
imagine.
Oh, it'll wreck your kidneys. You let it go long enough, your kidneys will get shot. We actually had a lady in the ER when I worked in the ER. She used to come in every week in diabetic ketoacidosis.
Every week?
Every week. And then eventually she lost both legs below the knee, and she was only 38.
What?
Yep. And then after that, she would come back, and then her kidneys were shut down, and eventually she died. I think she died before she turned 40.
Fuck, man.
She just didn't take care of herself.
Yeah.
You know,
Fuck, that sucks.
it does.
No. Yeah,
So
well,
so you have the obstructive symptoms. That's what we would use an alpha blocker for, okay, to help the prostate relax that bladder neck, relax that tissue so you could urinate through it, okay? There's other drugs finasteride and dutasteride, the 5-alpha reductase
Hmm.
inhibitors, I prescribed a lot of those. Now, I don't
Yeah.
prescribe them for guys on TRT. There's no reason we need to block 5-alpha reductase. A lot of guys want to take it for hair loss,
Yeah.
right? So we do talk about that. And
Mhm.
Propitia's dose for hair loss is 1 milligram a day. I was giving out Proscar, and Proscar's 5 milligrams a day. So
Jeez.
yeah, it's 5 times the dose, but it does shrink the prostate up to 30% of its original volume. So if you have a guy who has a massive prostate and he's clearly concerned with his urination, or it's causing some type of physical issue, like he's obstructing and he's getting into retention and he's not emptying, and that's going to cause potential problems. Because if that's unmitigated, you could get what's called hydronephrosis, which is the kidneys that empty into the bladder back up to the kidneys because it has nowhere to dump the urine because it's so full.
Yeah.
Okay, that's when it's really bad. We might have to consider using one in that case. And I know a lot of guys I use this medication, and it was more of a necessity, not necessarily a,
Yeah.
oh,
Right.
I've got dribbling or something like that,
right.
Um, and, we do talk about that a lot with like TRT and like, do we want to block DHT? And I think it has to get a discussion, at least even for hair loss or even for BPH, severe BPH is, okay, this medication the benefits of what it's going to help for the situation may completely outweigh the potential risks that we
Right.
have
Right.
of like getting some erectile issues or that, because realistically, if at the end of the day, you have to pee, you know what I mean?
Exactly.
And if it's like, if that's going to keep you from having issues, then you might just have to be like, okay,
You have to live with
that's
it.
just what it is. Right.
Hmm.
We didn't really have a big profile with it, in terms of like guys that had too many issues. And if we did, we stopped them and, tried to move things on. And then if meds don't work for the prostate, then now we're talking about surgery,
Jeez.
so we're talking either having a TERP, which is a transurethral resection, where they go in and mechanically burn that tissue out. They use an electroloop and they kind of take it and kind of shave it like a cheese knife,
Yeah.
and they just cut pieces out and they open the channel back up so it's bigger. Okay, that's the gold standard method. They have green light laser, which basically does the same thing. It just uses lasers and pew 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 pew, and burns it and basically vaporizes the prostate. They have a technique called a HOLEP, which is a holmium laser enucleation of the prostate, and it's kind of like a lightsaber that chops
Really?
the prostate. That one's actually really fucking slick, but the skill ceiling to use holmium lasers is high. So
Yeah.
like you have to like get a lot of training, but like it's
Like a
like
fucking
Luke
Luke Skywalker.
Skywalker in
Yeah. I was
there.
just
Yeah.
gonna say it's like.
They have what's called a cryo knife, which is sort of like freezing it. They have one called Resume, which is steam. They have one called a Eurolift,
Steam.
which, yep, it
Fuck.
shoots puffs of steam in there and it cauterizes, or not cauterizes, basically causes necrosis of the prostate, so it opens up the channel.
Hmm.
Okay. They have one called the Eurolift. We did that, which basically anchors it back. Okay. It sticks like harpoons into the side of the prostate and leaves like these titanium anchors. And there's like a string attached to it. And on the other side, there's another anchor on the other side. It's like a bar. And it just takes the prostate and goes and yanks it open.
Really?
Mm-hmm.
Damn.
And then they also have, they have this other product called Urotine. I don't have much experience with that, but basically it's like a compression device. It's like a really, like what they do is they stick it in and it just presses on the prostate, but it presses so hard it like stops the blood flow into the prostate, and it
Ah.
just causes it to die and necrose. And then they go in and then they grab it and pull it back out, and then the prostate
So is that like
apparently
what they do? Like what's that? Like the balloon that they do for like arteries? You know how they put that in
kind
there?
of, I think it's sort of the
Kind of
same
like that same
principle.
thing.
I don't have much like experience with it. I can't imagine that it's pleasant, because if that's putting
No,
that amount on your prostate, probably hurt.
doesn't sound fucking
No,
pleasant.
I'd rather just go to sleep and then just bzz, 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 and then be done.
Yeah.
So, but we had, I mean, there are obviously complications with surgeries like that.
Hmm.
I've seen guys be incontinent after the surgery, where they're just leaking urine all the time. It's rare, but it can happen. Um, but most of the time, it really makes a big difference.
Yeah,
So,
I would bet. I mean, I'm sure if you're at that point, you'll fucking try anything
right.
to get it fixed.
Basically,
Yeah.
becomes really inconvenient. So,
Yep.
um, Bladder wise, then obviously the treatment's a little different. You're going to be using medications to kind of slow things down. So a little bit of opposite here, right? If your bladder is trying to tell you you have to pee all the time, it's the stretch receptors in the bladder which stretch, and that's what tells you I have to pee.
Right.
We have to kind of calm down the bladder so it's not sending nerve signals to tell you to pee all the time. So we use medications like anticholinergic drugs that kind of slow that pathway down. There's a couple other drugs like Myrbetriq that's out there, kind of does the same thing, but a different pathway. And then they have posterior tibial nerve stimulation. We didn't do that in our office. It's called PTNS. They have bladder stimulators that can kind of calm it down. And then you have the procedure that I did, which is intravesical Botox. So we put Botox in your bladder.
No shit.
Yeah, we inject it right into the wall, right into the muscle. So I'd put a scope in, okay? And this is my claim to fame. I am the first non-physician in the U.S. to perform this procedure.
Really?
Yes.
No shit.
Yep. Yay, jing, ring a bell.
There you go.
Yeah, I was.
You should put that on your TikTok account.
I found out through the AbbVie rep, and he's like, like nationally, you're the only guy that's like a nurse practitioner or a PA that's doing this procedure. Like, I don't think there's anybody else doing it.
Nice.
And he's like, the next time I saw him, he's like, I checked into that. Like, no, you are the only one doing it right now. And then like 3 months later, like 5 other people were doing it.
Right.
So
word gets out.
Right. But anyway, you put we put a cystoscope in, and the cystoscope has a like a little channel, and we run a Labary like needle down through it. And it's like a long, flexible needle, as there's the needles in the end, but the whole thing's flexible and it's hollow. Okay. Mm-hmm. And what we would do is we would draw up Botox. I'd probably use like 250 to 200 units, okay, of Botox. And what we would do is I'd go into the bladder, and then once I'm in there, like we have to fill the bladder up with saline. So there's a saline port, and it's just dumping water in the whole time. And that way stuff doesn't get stuck on the lens or anything like that.
Right.
And then you have to blow the bladder up, because if you have to kind of make a dome out of it, because if not, like everything's like flopping on you. You know what I mean? And you can't maneuver because it's just like, you're in like this small space. So you have to like let the liquid kind of fill the bladder, at least 100, 150 cc's, get some space that you can work with. Okay. And we would stick, they would put a catheter, and we would stick lidocaine in the bladder before we did that. Okay. We'd let them sit with the lidocaine for like 20 minutes, and then we'd pull the catheter out and drain everything out.
Oh, okay.
Okay. And then that's when I would go in with the scope. Okay.
Right.
So we put the scope in, and I'd fill the bladder up. We would assess our landmarks. That's always the first thing I do. So I'd find the ureteric orifices, which is where the urine comes in at the bladder neck. You have 2 holes. That's where your ureters come down from your kidneys. Right. And that's where the urine shoots into the bladder. Okay. That's how they fill. And you should be able to find those, one on each side. Okay. And then we're looking at the posterior wall. I'll look at the dome, anterior wall, the whole 9 yards, kind of survey. Everything looks good. No cancer that I could, no gross cancer lesions or anything. As it's filling up, I'm doing this. And then once we're good, we'll shut the water down to like a really slow drip, not off, but like just where it's just barely going in. And I'll take that needle, and it's already like partially threaded through the scope. Mm-hmm. And I'll keep feeding it down while I'm looking into the scope, and then it'll pop out on the end, and you'll see it like, doing that. And then once it's out, well, there's a push needle port on the end. You push it in, and you turn it to like the degree of depth that you want to go. And that's how far the needle pops out at the end. So I would set it to like 4 millimeters or something like that. And then they would hook the Botox to it. Okay. And then what they would do is I would basically find a spot, and we'd be looking at the black of the bladder wall, and we'd go boop, and we'd stick the needle, and it would jab right into the bladder wall. And then we'd inject, 10 units of Botox or 1 cc, which it was 20 units of Botox. Okay. And then we'd pop it out, and then we'd find another spot, and then boop, and then just inject it into the bladder wall.
No shit.
Yeah. We just paint the whole bladder wall, like, in like a pattern, and just hit it with the Botox. And what that does is it paralyzes the bladder. I mean, people get it in their face to kind of like paralyze it a little bit.
Yeah.
That's what it does. It does the same thing to the bladder. And then it keeps people from feeling they have to pee all the time.
No shit.
So
That's
yeah,
wild.
it works great. Works wonderful. Low risk procedure. Isn't all that painful. I obviously did it in women more than men, but I did a few in men, and it works pretty well.
And if you just do it one time and then it's done, like, or
No,
do
you
you
have
have
to
to?
have it done roughly about
Yeah.
every 3 to 4 months.
Oh, really?
Some, I mean, the people that had like a lot of medical comorbidities, like your diabetics that
Mm.
had high sugars and stuff, you had to do it on them more often. Sometimes you could do it once a year on some people.
Hmm.
So, yep,
Damn. That's fucking wild.
yeah, it's pretty cool.
Yeah. That's crazy shit, man. There's a lot of shit you learned in this stuff. I'm telling you.
That's just one part of it. I mean, then we had
Yeah.
cancer, and then we had, we won't get into that, but I mean, it's not just prostate cancer; it's kidney cancer. All the cancerous lesions, the non-cancerous kidney lesions, right? Cysts, oncocytoma, which is a benign growth. XGP, xanthogranulomatosis pyelonephritis, which is what that is.
Jesus.
All these different things that you would experience. Obviously, renal cancers, RCC, which is renal cell carcinoma, clear cell, small cell. There's just a bunch of stuff that you do, and that's just the kidney. And then there's adrenal tumors. We didn't do a lot with adrenals, but that was also part of our stuff. And we have bladder tumors. Okay. So urothelial cell carcinoma, transitional cell carcinoma of the bladder that we would see. And then prostate cancers and testicular cancer, seminoma and non-seminomas. So,
Damn.
and yeah,
That's
so
fucking wild shit, dude.
that's the cancer portion of it, right? And then we have obviously all of our urinary issues. We have kidney stones, which I think we're going to talk about here in a little
Yep.
bit. Kidney stones, we saw a freaking ton of those,
Yeah.
like ton of kidney stones.
Yep.
So,
I had a guy I used to work with that had kidney stones constantly. And the doctor kept telling him he used to drink iced tea like crazy.
yeah, oxalate, super high in T.
Yep. And he was just
So,
like, stop drinking it. And he was like, no, I love it. The doctor was like, what the fuck is
so they're just going to have kidney stones
right. I mean,
chronically.
what the fuck do you want me to tell you? Like,
Yeah.
it's that simple. He just didn't do it, but
No.
whatever.
Yeah, man.
All right. Well, I guess question number 2, does testosterone make the prostate bigger and is that dangerous?
It doesn't make it bigger. Okay. There's no clear cut. There's nothing that, no literature, no current governing body that says that it makes it larger. Okay. So, Endocrine Society, AUA, and EUA, that TRT does not cause BPH. Okay. But it can potentially exacerbate some urinary symptoms in some men if they
Hmm.
had them prior.
Right. Okay.
Okay.
Let's see. How do I know if urinary problems are from TRT or just getting older?
You probably would have had the urinary problems. So
Yeah.
here's the thing. I will just say this.
That.
As you age, BPH affects, let me see if I can get this right. 50% of men age 60. What is it? 50% age 50 to 60, 70% age 60 to 69, and 80% over age 70
It
have
affects that
BPH.
really.
Yes.
Holy shit.
Right. But here's the thing. Just because you have an enlarged prostate and you have some type of urinary symptom, like let's say you have to stop like every 2 hours, 3 hours, right? And it's annoying, but it doesn't necessarily mean it's causing you harm.
Right. Okay.
Right. So it doesn't necessarily mean it needs treated. So when we would have guys come in for treatment, I'd be like, they're like, well, they sent me, I was at my family doctor and I said I was up 2 times a night to pee. And they're like a 70-year-old guy. And to be honest with you, nocturia, getting up at night to pee, is obstructive and irritative. So it could be the prostate, it could be the bladder, your sleeping habits, how much caffeine, like, how much
Yeah.
sleep you get, like, do you smoke? Like, there's a lot of things that go into that. There's not just like one thing
Hmm.
that they can put there. And they'd be like, yeah, I'm up 2 times a night to pee. And so a normal, like, I don't have any data behind this, but I can tell you I've seen thousands of patients in the urology office over the 6 years that I've worked there. And I will tell you, on average, men will get up 1 time a night per decade of life starting in the 50s.
Oh, really?
So 50s once, 60s twice, 70s 3 times, and then all bets are off after that. It's kind of it can
Jesus.
be anywhere. Doesn't necessarily mean it'll be more, but that's kind of the general pattern I saw. Okay. So if you're, if they had like a 63-year-old guy and he's like, yeah, I'm up 2 times a night to pee. Pretty normal. Okay.
Normal.
Like
Okay.
pretty much part of the course for a 63-year-old guy. And they would send him to me and I'll be like, well, are you bothered by that? And he's like, I don't really care. I'd be like, see you later.
Yeah.
Because there's nothing for me to do. His bladder's empty. He's up 2 times a night, but he pees fine during the day. He just said that he was up at night to pee, and they sent him in.
No
But it's
shit.
not necessarily, it's not a bad thing. Yeah, it's a symptom, but it doesn't mean anything's bad. Doesn't mean you have cancer. Doesn't mean anything. It just means you're up 2 times a night to pee. What did he do? Join the
Yeah.
club.
Right. Well, that's exactly it. I mean, all your buddies are probably doing it too.
Yeah, and maybe you aren't. Consider yourself lucky. But at
Yeah.
some point in time, you're probably going to get up in the middle of the night to pee.
Fuck.
It's almost like that for everybody, unfortunately, as they
That
get older.
sucks.
We're going to try to prevent it as much as possible.
Yeah. I only get up occasionally, but it depends on how much I drink before I go
Yeah,
to bed.
and that's obviously going to play into it as well. I mean, does it matter if you get up 1 time a night to pee? Most people don't care, Now, if you're up 4, 5, 6 times a night to pee, yeah, that's disruptive. You're not getting great sleep, and you're going to be tired during the day.
Yeah.
And see, that's like a double-edged sword. We would see that
Right.
too, especially guys like that are, I'd say, 70 plus retired, kind of not getting out of the house. What happens is they sleep so crappy at night, then they nod during the day.
Right. Right.
They're sitting in the chair and they're taking all these like naps, and then they
Then
can't
don't
fall asleep.
Right.
Right.
Yeah.
So then we would see that too. And then they're like, well, I'm up at night to pee. And I'm like, well, are you really up at night to pee? Because it sounds to me like you're not sleeping and you're just going to the bathroom.
Right. Exactly. Yeah.
Like you're
up
awake and just
watching.
peeing.
Correct. Yeah. It's just a normal. Yeah.
Right. So it's like kind of getting that story. You have to figure that one out too. So there's definitely some nuance and kind of teasing that out.
Yeah. Oh,
So.
that makes sense. Let's see. Can TRT make it harder to fully empty my bladder? Guess we kind of even talked about this a little.
Yeah, I mean, no, not necessarily. It shouldn't make it any harder for you to empty your bladder whatsoever.
Okay. Let's see. Does TRT raise the risk of prostate cancer or urinary tract issues?
No, for prostate cancer. I know we've discussed that
Yes.
at length, and I think we have a prostate cancer episode that we did earlier on. So just go listen to that about that. But no, TRT doesn't cause prostate cancer. And the Traverse study, secondary endpoint in 2023 was no increased risk of prostate cancer
Right.
for guys on TRT. I will say that study wasn't the greatest, and I have my criticisms of it, but nevertheless, no, there was no risk. And what was the other part of the question?
Or urinary tract issues?
Again, just no, it's not going to increase your risk for developing an infection or prostatitis. I know we talked about that last week. It's not necessarily going to mean you're going to develop urinary tract infection. So full disclosure, urinary tract infections in men, like how women get them, super rare. Men don't get urinary tract infections, hardly at all. Okay. They definitely can.
Yeah.
But it's not a common thing. Men typically get prostatitis. Okay. Like if I had a guy that came in and they're like, it hurts at the tip of my penis when I pee, and I feel like I got to pee all the time, and I didn't beforehand, we could do a rectal exam and I could palpate their prostate, and if they're like, oh, it's a little tender, they 100% have prostatitis. Okay, we're going to treat that with antibiotics. Okay, if it's not tender and they still have those symptoms, I'd probably still treat them because chances are they're going to get better with the antibiotics. Okay, and a lot of times, the reason this is because prostatitis, if I were to check a urine to see like, hey, does this urine look like it's infected? It doesn't look like it's infected. It looks normal because the infection's not in the urine. It's in the prostate.
Right.
Okay? So that's the big difference between male and female kind of urinary issues with infectious, at least.
Okay. That makes sense.
Yeah.
Lastly, does TRT cause kidney stones?
That's a good question, actually. I'm glad you asked that. Directly, no. Indirectly, potentially. and it's only going to increase your risk for uric acid stones. Okay. Testosterone, if you are prone to, let's say, gout, which is obviously an accumulation of uric acid, testosterone can uh, increase uric acid accumulation. And if you have gout, it can make it worse. Actually, I have a patient that had a gout flare after he started TRT. So, um, so if you are prone to forming uric acid stones, theoretically, you potentially could have an increased risk of uric acid stone production. Now, with that being said, uric acid kidney stones are also the only kidney stones you can dissolve inside the body. You can't
Oh,
dissolve any other stone once it forms, but you can dissolve uric acid once.
okay.
Okay. So the treatment for that's urinary alkalinization. So, the simple thing, your doctor may put you on a supplement called potassium citrate. Okay. Which it's the citrate that ends up alkalinizing. When I say alkalinizing, increasing your urine pH. Okay. And that can help break down those uric acid crystals in the urine. Okay. Another thing you can do that's kind of quick and dirty, and this is what I recommend for people that is to take a half teaspoon of baking soda and 8 ounces of water and drink that twice a day.
Oh, really?
Yep. Works.
No shit.
Yep. There's data on that too.
Oh, really?
Yeah. And so again, it's just alkalinizing your urine. It's turning it
Right.
more pH neutral. Okay.
Mm,
Now we don't want to swing the pendulum too far the other way, or you'll
right.
start to form calcium phosphate stones, which are a bitch too. But we want to take a pH that's like 5 and we want to make it like 6.5, 7.
Okay.
Right. So
Damn.
there you go.
Well, I'll tell you what. TRT and urinary health. Never thought we'd talk about that, but damn,
Yeah,
that's
I mean,
pretty deep, man.
I think that the takeaway is TRT isn't necessarily going to cause you to have
Right.
any prostate and or urinary issues. They're going to be independent of the testosterone. Okay.
Right.
I don't have anybody in the clinic that I'm currently dealing with any urinary issues from TRT. Now they may have had them prior to starting.
Right.
Okay. But it's not like, hey, I'm on TRT for a year and all of a sudden I'm
This happened.
peeing like a
Right.
racehorse, right? That doesn't happen.
Mm,
And it's not commonly seen. So that being said, if you're on TRT and you develop urinary symptoms, chances are you probably had them going in, and now
right.
it's just like it's more noticeable. And you're
Hmm.
like, well, it's got to be that TRT that's causing it. And I'm not saying that it's again not per se, but it's likely you had some of those issues,
Right.
that are just kind of coming to a head later. So
Well, I guess as you get older, there's nothing we can do.
right.
Yeah.
It just
Just gonna be.
happens as you get older. So, most guys we would do digital rectal exams on would have um, prostates around 30 to 40 grams. Okay. Which a normal prostate's like 15 to 20.
Mm.
So it would be definitely enlarged. Okay. But most guys that had your, sizes of that prostate didn't bother them. They didn't really have any issues at all.
Oh, okay.
Yeah.
So that's pretty common then. It's not like,
Super common to have guys with enlarged prostates and no symptoms. Yeah.
no shit.
Yeah. And I've even had guys with like really tiny prostates, you can barely feel anything and, have terrible urinary symptoms. But, they're also, BMI's 35 plus, body
Mm,
fat's probably, 28% or greater.
yeah.
They don't watch what they eat. They drink soda, like
Hmm.
there's a lot that goes into it.
Yeah. Yeah, exactly. There's a lot that goes into a lot of things. That's why people just throw it out there. TRT
Yep.
causes this. I'm like, wait a second. Take a step
No.
back.
It's a hormone. I mean, we all have it naturally. We're just giving ourselves more of it. So,
Yeah.
it's not like you were devoid of having any testosterone in your body before you started TRT. You just didn't have enough to cause symptom resolution, and now we're giving you more to help that symptom resolution. But if it were like a true, let's say, related to that actual testosterone, you probably would have had it before I gave you more of that. You know what I
Right.
mean?
Yeah. That makes sense. Well, I think everyone learned something today for
Hopefully.
sure. I did.
I like talking
Urinary
about this
health.
stuff. I mean, I did it for so long. I really enjoyed it too. That was the crazy stuff. But I like the TRT stuff too. I just like helping people out at the end of the
Yeah.
day. That's really what I enjoy. So if I
Yeah.
can help somebody, they're really bothered by this, we can make it better, then mission accomplished.
Yeah. Yeah. It's like it seems that the TRT and the prostate that's has a negative, there's a lot
Yeah.
of just negative, I don't know,
The
uh,
stigma.
the stigma, right? The stigma
Yeah.
of it. There's always like, oh, it's going to cause prostate then. It's like,
Right.
well, who told you that? The guy at the gym? It's
Yeah.
like,
I mean, it was, it's as we get more data, as things progress, you have to, again, I always preach, you have to be open to like different ways of thinking. You have to be open to accepting the fact that, uh, things will change. And it's funny. I'm listening to the Joe Rogan podcast today. I'll give you a prime example of that. And he was talking to Andrew Santino, and he was talking about how like AI, like he's trying to explain this analogy, like AI is going to be like the next thing, but like we're in a position where like we don't think it can be like the next thing.
right,
You know
right.
what I mean? So he's
Yep.
like, yeah, I'm a arrowhead thatcher. You know what I mean?
Yeah,
And he's
right,
like, yeah, and then we made guns.
right. Exactly.
And that guy didn't need to make arrowheads
Right.
anymore
I've been
because we
doing
made
this
guns,
forever and I don't have anything to worry about.
Right. So it was like kind of like the progression on that. Like as you keep going, like, okay, you might have never thought of that, but now
Right.
it's there and you don't need that anymore. So
Yeah.
that's how it is in medicine too.
Yeah.
Just because we did it one way for 10 years doesn't mean something could come along and be
Exactly.
like, bro, nope.
Yeah. That's the
Forget that. Here's
old
this.
way of thinking.
Yep.
It's the
So
new way.
you have to be malleable in this space for sure.
That's the only thing that excites me about AI is like that part of it, the
Mhm.
health part of it, like how it's taking science and moving it, forward
I
much
agree.
quicker,
I think there's a lot of potential implications for increasing the availability of ready use data,
Hmm.
and helping create models. I think we're truly in a really interesting time frame, and the next 10 to 15 years are going to be very transformational.
Yep.
Uh, I hope, as long as we can stop yelling at each other for everything
Right.
and hating each other for
Yeah.
really stupid reasons.
Right.
If we can all just kind of find some common ground and get along again, and all get back on the same page, like why, it was in the 90s.
Hmm.
Um, I think we'll have fantastic progress. But if not, then, you know,
Yeah. Yeah. I don't even, my thing is, I don't even care if it increases longevity of life,
mhm.
but I want the quality of life to go longer into that. So if you're going
I,
to live to 75, I don't want to
yeah,
be, you know, 75 years old and feel like I'm 80 years old.
I think guys in our generation, guys that are like in their mid 40s right now, I honestly think we'll be like the first generation that's living over 100.
Hmm.
That's like really good over 100. Like,
Right.
I think you're going to start to see people push like 120, upwards of
Damn.
that. But like a guy's going to hit 100 and he's going to be like a 70-year-old now.
Right. Exactly.
You know what I
Yeah.
mean? Like
Old,
he's
but
still going to
older,
be
but not.
playing golf on the golf course,
Right.
and he's
Right.
100 years old and you're like, you're 100, it's
Yeah.
there's going to be like, because you think about that. I mean, I'm 41, you're what, 46?
46. Yep.
46. So I mean, you got another 55 years to hit 100.
Hmm.
That's how fast things are moving, like technologically. I
Right.
mean, the iPhone came out in 2007.
Right. Exactly. It's
You
exactly
know,
right.
it's not that long ago. It hasn't even been
No.
20 years yet,
No.
And um so there's a lot that's changing, and it's changing. The further we go, the quicker the change happens.
Yeah. Yep.
Oh.
I have to go break the news to my wife. She's got 55 more years. Mhm.
I
It's-
mean, obviously, we can destroy ourselves with unhealthy habits and eating bad food, and all the other things we know that can cause harm.
Right.
Can cause some detriments or cause cancer to happen or this, that, and the other. And but I think as a whole, I think we can extend the lifespan and the quality
Yeah.
of the lifespan too.
Exactly. That's what I'm concerned with. The quality.
Hmm.
It's TRT and tadalafil till the end. Fucking
Yep.
hammer down. That's
Hey, I mean, they came out that study that the tadalafil reduces your risk for Alzheimer's.
yeah, I saw that.
Yep.
Yep.
So
Does a couple
take your
other things too.
tadalafil. Yes, it does.
Hmm? Big fan.
Good. Big fan too.
Yeah,
10 out of 10. Highly recommend.
for sure. Yeah, the pump, like the gym pumps are insane.
They are
My
nuts,
veins
dude.
are just crazy.
They are well worth it. And I actually take on some days I'll do a 1 mil injection of biaminos, and I'll hit up the gym. And that's L-citrulline and L-arginine
Oh,
injection.
okay.
Yeah, and we have it at the clinic. and I'll like give myself some like 30 minutes before I go to the gym. Sometimes I have to be careful though, because like I'll be lifting and I'll get like kind of like lightheaded,
Oh, really?
and I'll feel like I'll
Pushed
be
it
like,
too
because I'm
far.
just like so dilated. I'm like,
Right. Yeah.
feel like I'm gonna like pass
Fucking
out.
black out.
And I'm
Yeah.
like sweating profusely,
Yeah.
So
Oh, God, that's great.
yep.
Well, I'm going to go break the news to my wife. She's got 55 more years, so stretch out, sweetheart.
Want to be limber.
Yep. We're not stopping. We're dropping the green flag like fucking Daytona. Hammer down. Because we ain't fucking, no breaks, man.
No
All the
breaks.
way till the end.
Love it.
All right, Josh. Well, I guess what? I mean, that was, I learned a lot. I'm sure everyone else learned a lot.
Yeah,
There's
keep
a
them
lot of
coming. If you
things.
have any other subjects that people are interested
Yeah.
in, send us a message. I'll
I
be
don't think
happy to
I've
talk
ever
about them.
heard anyone talk about urinary health and TRT. Like
No,
I mean, like I said, it's always prostate, and it's always
it
the
comes up.
negative part. It's
Right.
always like a negative. There's never anything positive. It's always, that stigma bullshit that
Mhm.
follows this stuff. But that's the other thing that I think will slowly start to dissipate is the stigma of this.
Yep.
Peptides, I think, are helping with that stuff.
Yeah. We just got to
Yeah.
get the enclomiphene people off of
And
TikTok.
fuck them people. There's no, like the guy that just doesn't, you've talked to him a million times and told him, just that it comes to a point where I just say, all right, bud, you do you. I just actually fucking commented that an hour ago on someone else's thing when he said something about enclomiphene. I said something negative about it. He wrote something smart back, and I just wrote, bud, you do you. And then he
Yep.
wrote, same to you. That's it. That's it. That's all I'm going to say.
Hey, you were able to end it
That's
peacefully.
what exactly. Just like the political divide, just you do you, I do me. We can coexist.
We can agree to disagree.
Right. I got to go to my bedroom with my wife. So fuck off. So, all right, Josh. Well, listen, I guess next week we have a guest.
We do, yeah. So next week we're gonna have Dr. Michael Day on. He's a friend of mine. He's a longevity expert and does longevity medicine. He's also an orthopedic surgeon. Really nice guy, brilliant. He's written a book and several marathons. Yeah, really all around really cool guy.
Good.
So I think it'll be a really interesting conversation. We can ask him some questions on longevity. If you're listening to this week, come up with some questions that you may have about the anti-aging, like longevity space, and send them to the TRT dad here,
Yep.
and we can ask him next week when he's on.
Yes.
So.
And you can email me the trtdad@gmail, or we can get on TikTok. Don't send emails through the podcast because I cannot. Well, I guess you could send the questions. I just won't be able to respond to them.
Respond right.
Yeah. So, but I guess you could do that, but I won't be able to respond. So don't get angry if I don't respond. I just can't.
Yep.
I'd love
Disclaimer.
to. Yes. So, all right, Josh. Well, next week will be another good one. We'll have a guest, and it will be episode number 50.
Oh, it's perfect. That's
Yeah.
great. And at some point in time, we'll probably have to let everybody know about our announcement. But
Yeah.
we
That'll be
don't have to give it to him just
maybe
yet.
October. In October.
October, yeah.
Yeah. Give
But
everyone
we can breadcrumb a little bit right now.
Yeah. Sprinkle, sprinkle it around. Yeah. I'll have my wife in here with those confetti things and stuff. And we'll shoot it in the air and all that stuff. And then I'll have to clean it up. So, all right. All right, Josh. Good talk. Next week will be a good one. And like Josh said, if you guys have any questions, you know where to reach us. And until next time, we'll see you later. Take care, Josh.
Yep. See you, brother.